Next, I would like to welcome Dr. Vrinda Agrawal. She's going to talk on dual blockade, SGLT-2 inhibitors and DPP4 inhibitors. Dr. Vrinda Agrawal completed her MBBS in GSVM Medical College, Kanpur, and she trained in America and completed her American Board certificate in internal medicine and endocrinology. She has been she was an endocrine faculty in Franciscan Health System in the United States. Her area of interest, and she's an expert in using technology like insulin pumps, CGMS, and in managing diabetes. She trained in the performance of performing thyroid ultrasounds, and FNAC, biopsy of thyroid nodules, and interpretation of the results. She trained in the prestigious MD Anderson Cancer Center in Houston, managing endocrine cancers, endocrine-related cancers like thyroid cancer and adrenal cancers. She's has had several publications in peer-reviewed journals and is an active member of many international professional societies. I love to welcome Dr. Vrinda. Please, you can start your presentation.
Thank you, sir. Thank you so much for a very warm introduction. I am Vrinda, and so I'll get started right away in the interest of time. So, to set the tone right for the talk today, I would emphasize that it's very important for us to, be prompt or be more aggressive in managing our patients with diabetes. So, initiate early and initiate right. So this is a brief overview of how the talk would be today. Goes beyond saying, I think we're all witnessing another pandemic of diabetes, and something we should not be proud of. India is actually at the epicenter of this epidemic. And what's striking to see is that more and more young Indians are being diagnosed with diabetes. So is that because of a change in our dietary habits, lifestyle? With COVID, a lot of people have started working from home, so reduced physical activity. And while we talk about the numbers always going up, the sad part is almost 50% of the individuals with type 2 diabetes fail to achieve their blood sugar goal defined by an A1C of less than 7%. So, today I'm going to basically focus on two classes of medications, anti-hyperglycemic agents, which are basically the talk of the town today, DPP4 inhibitors and SGLT2 inhibitors, with a focus on two studies. So the first study is an initial study, which basically outlines to be initial combination therapy with vildagliptin, which is a DPP4 inhibitor, plus metformin in drug-naive type 2 diabetic patients. This was a 24-week study from Asia. Essentially, the idea was to see that, if we use combination therapy early on for Indian subset of patients, would that, result in a more robust early glycemic control because of the complementary mechanism of action of the two drugs, and also subsequently improve compliance to medication. As I mentioned, with this study, we aim to identify the data, on the use of this combination treatment to assess its real-life effectiveness in the Asian population. And we have to remember, we as Asians, tend to, demonstrate poorer glycemic control and have a heightened cardiovascular risk even at baseline. So this was a prospective observational multi-center study, 24-week study conducted in 4 countries across Asia. Enrollment criteria included men and women more than 18 years of age with a confirmed diagnosis of type 2 diabetes with an A1C more than equal to 7.5%. And all these patients were deemed to be drug naive. They did not receive any kind of anti-diabetic medications before. For the Indian subset, A1C more than 8%, these patients were identified, and then the physician recommended a combination of vildagliptin and metformin. These patients underwent glycemic assessment at baseline, at 12 weeks, and at 24 weeks. Now, just to highlight the cardiovascular risk factors for this group of subjects, the mean age of the patients was about 49.6 years, so relatively younger population, and almost 55% of these were men. And as I mentioned before, South Asians have a heightened predisposition towards cardiovascular risk. Other than that, 66% almost patients reported one medical condition which could heighten the cardiovascular disease risk, including dyslipidemia, hypertension, or being overweight. The primary endpoint was defined by a change in A1C, from baseline to week 24. Secondary endpoints included HbA1c change from baseline to week 12, and then, a proportion of patients achieving an A1C of less than 7%, change in body weight, and the change in A1C or glycemic improvement was also categorized by subgroups. So for the primary endpoint, when we look at the change in A1C from baseline to week 12 or week 24, the initial combination therapy resulted in a statistically significant HbA1c reduction both at week 12 and 24. And almost about 40% of patients were able to achieve their glycemic target of HbA1c less than equal to 7%. When you look at the reduction in fasting blood sugars, post-meal blood sugars, again at week 12 and 24, they did show an improvement compared to baseline. There was also a notable reduction in body weight with the combination therapy at week 12 and 24. When you actually, categorize the results along, according to the subgroup, what we see, and I think this is what we also understand, that patients who had the highest, or they were in the category of high baseline HbA1c, experienced the most A1c improvement or reduction compared to those with lower baseline HbA1c. And this was demonstrated by the delta of change, which we see for baseline HbA1cs of more than 10%. That was the maximum improvement that was seen at week 24. The subgroup analysis also demonstrated that the glycemic improvement, the change in A1C, stood irrespective of the age of the patient or the BMI, or even the baseline comorbidities like hypertension, dyslipidemia, cardiovascular disease risk. So when you talk about the overall summary from this study, so we understood that almost 30% of this patient had cardiovascular disease risk factors, 21% were obese. They tended to have a higher baseline A1C of almost about 9.3%. They were drug naive, and they relatively demonstrated a younger group of subjects. So with this, what we understand is that the initial treatment with vildagliptin and metformin actually resulted in significant improvement in glycemic parameters, which was measured in terms of HbA1c at both week 12 and 24. Impressive was that almost 40% of these patients were able to achieve a target A1c of less than 7%. This was overall well tolerated, no significant concern for adverse events. And then when you talk about various subgroups, the HbA1c improvement, was consistent throughout all these subgroup analyses. Other observations from this initial study was somebody may notice that there was a higher reduction in overall HbA1c in this study population, but that could be attributed to a higher baseline A1c that this population demonstrated. And almost 40% of these patients were able to achieve the target A1C of less than 7%. Again, maybe possibly because a higher proportion of this study population, had a higher HbA1c to begin with. So, how is this relevant to us? Because, this study shows that, DPP4 inhibitors, an early initiation of a combination of vildagliptin and metformin may actually help our patients who are drug naive with poor glycemic control, younger of age, and also signifies that we'll be able to achieve this glycemic improvement more promptly. So something which could actually help routine clinical practice patients. So again, to summarize, this was a drug-naive population with type 2 diabetes, younger age group, Asian, with a high baseline A1C and associated cardiovascular risk factors, and they demonstrated good and prompt glycemic control with this combination. Now, moving on to the next study, I wanted to highlight the importance of glycemic variability and post-meal hyperglycemia in Indian type 2 diabetic patients. So what is glycemic variability? Oftentimes our focus has been on glycemic control. We measure the fasting blood sugars, HbA1c. But glycemic variability, increasingly we are becoming aware that this is a very important variable. It is defined as the fluctuation of blood sugars over a given interval of time. That could be from visit to visit, or short-term glycemic variability could be within the day, defined within the day or between days. And this is an example to show that there may be two patients sitting in your clinic with a similar A1C of say 8%, 7%, but one may be having more highs and lows, more hyperglycemia and hypoglycemic episodes, and one with a more stable blood sugar control. So essentially, if you would just measure the HbA1c for these patients, you may be mistaken that these patients may be at good glycemic control, but eventually it's the variability that also concerns as physicians. Why? Because we do understand that increasingly we are recognizing that glycemic variability in itself actually is a risk factor for cardiovascular disease events, increases the risk for development of macrovascular complications. So how does that happen? Well, of course, post-meal blood sugar spikes, oxidative stress leads to endothelial dysfunction and subsequently increasing the risk for cardiovascular disease events. So we as Indians, we love our food, and goes beyond saying that I think we have a more like carb-rich diet. There was a study, the START study, which aimed to understand the dietary patterns of the Indian type 2 diabetic population. What we saw that irrespective, whether we have diabetes or we don't have diabetes, the total carbohydrate content is about 64-65%. So again, emphasizing that we are carb-loving people. What's important to understand is that because of our dietary patterns, our dietary habits, we tend to demonstrate a higher prevalence of insulin resistance, metabolic syndrome. There is a greater risk for developing diabetes and prediabetes, and that has to be taken into account when we are, managing diabetes in our clinics. So this is the REMIT GV study, the glycemic variability study, which aim to understand or compare the effect of remogliflozin versus dapagliflozin. These both the drugs are SGLT-2 inhibitors on 24-hour glucose profile assessed by CGM in Indian patients with type 2 diabetes. As I mentioned, remogliflozin is a novel SGLT-2 inhibitor. It's used twice a day. Dapagliflozin is another SGLT-2 inhibitor which is used once a day. And this study was essentially to see whether twice-a-day dosing of remogliflozin could offer a better chance at post-meal blood sugar control. When you talk about the study design, this was a randomized two-arm parallel group open-label study, uncontrolled type 2 diabetic patients on stable therapy on metformin monotherapy or a dual therapy of metformin DPP4 inhibitors were randomized to receive either remogliflozin in a dose of 100 milligrams twice a day or dapagliflozin 10 milligrams once a day. Again, the inclusion criteria: adults more than 18 years of age, diagnosed with diabetes, HbA1c more than 7% or less than 9%, 7 to 9% essentially. Anybody with the diabetic ketoacidosis or very high blood sugars were excluded. Now this is just a flowchart of the study design. So these patients underwent a CGM, a continuous glucose monitor implantation on day 1. From day 1 to day 7, this was considered as the pre-treatment phase, and baseline data was captured for this phase in terms of glycemic control. And then remogliflozin or dapagliflozin was started on day 8, and another 7-day data from day 7 to day 14 was collected for these subjects. So this was called as the post-treatment phase 1. The study medication was continued for a duration of 6 weeks. And again, these patients underwent a second CGM placement on day 36. And again, data was collected over a period of 2 weeks, which was defined as post-treatment phase 2. When we look at the demographics, essentially both the groups were very similar in their characteristics, except that the duration of diabetes in the remogliflozin group was slightly higher. When you talk about the glycemic parameters at baseline, again, very similar between the two groups. So now comparing the glycemic parameters improvement from baseline to phase 1, there was an overall improvement in the glycemic parameters measured by the mean glucose, time in range, the mean amplitude of glycemic excursions with both the drugs, except that it did not reach statistical significance for dapagliflozin when they measured the post-meal glycemic variables. Comparing glycemic parameters from baseline to phase 2, similar results, improvement in overall glycemic parameters, but did not reach statistical significance for post-meal parameters for the dapagliflozin group. Between remogliflozin and dapagliflozin, there was no significant difference between the glycemic improvement seen in both the groups. And so this is highlighted here, as I mentioned. So significant improvement from baseline to phase 1 and phase 2 with both the drugs, and this was the mean change in time in range, 70 to 180 milligrams per deciliter, and there was no significant difference between the two drugs. Then you specifically talk about the postprandial glycemic parameters. There was an overall improvement. However, the statistical significance was only reached in the remogliflozin group. When you talk about the other variables like the mean post-prandial glycemic excursions from baseline to phase 2, again, overall there was an improvement, but the significance was only statistically significant for remogliflozin at breakfast and dinner. When you talk about post-meal 1-hour change in glycemic parameters, again, a statistically significant reduction with remogliflozin, but not with dapagliflozin. When you talk about 2 hours post-meal blood sugar improvement, similar results wherein statistical significance was only reached with remogliflozin at all meal times, with dapagliflozin only at breakfast and dinner. So this is what our glycemic excursions essentially look like when we eat our carbs at all the meals. And with the plasma concentrations of remogliflozin, we postulate that this may actually lead to better post-meal hyperglycemia in our Indian type 2 diabetic patients. So glycemic variability is important. It's very, very important that we actually address this in our day-to-day practice. And it's been shown that post-meal hyperglycemia is an independent risk factor for cardiovascular disease. We understand that we love our carbohydrates, so it's important to address that same too. And in this study, we saw that both the drugs, remogliflozin and dapagliflozin, showed improvement in overall glycemic control, and slightly better control was observed in this particular study with remogliflozin when we talk about post-meal glycemic parameters. So with this, I would like to end my talk for today, and I'll be here, so if anybody has any questions. Thank you.